Great. Um, Good afternoon, good morning, good evening, everyone, whichever time zone you are. Welcome to the first of the Changing the Conversation Policy Dialogue series of the Strategic Purchasing Africa Resource Center. My name is Oludare Bodurin, and I am the Program Manager for SPARC, Strategic Purchasing Africa Resource Center. As you join, I would just like to walk you through some housekeeping rules and a few tips that could help to make sure that your engagement with us is quite fruitful and interesting. Great. We have an array of our speakers and moderators who will be engaging you on this policy dialogue series today. And in the course of the series, in the course of this conversation, they would all be duly introduced. Thank you so much for being here. We would like to request for your concentrated participation within the next 90 minutes, and we promise that it's going to be an interesting time for you. Just to run you through a few tips around technology, you can use the interpretation button to select your preferred languages. We encourage that you put your mobile phone on mute so that you can have full concentration and reduce distraction. Of course, we know that you are quite very busy, so we understand that you still have to keep in touch with work and all other engagements that you have. To ask a question, you can or share a comment. You can use the chat box feature, and you can also use the Q&A button to type in your question, or you can use the raise hand button just beside your name on the participant list. For your participation, to ensure an effective participation, we encourage that you are here and prepared to learn and contribute. We have panelists, but we believe that this is a community and we can learn from one another. We ask also that you can feel free to share the session highlights on social media, use the hashtag changing the conversation as the official hashtag for this policy dialogue series. And that's it. Join the conversation and let's make the change that we need to make on the continent. I would now turn it over to Nkechi Olalere, the Executive Director for SPARC, to give welcome remarks and let us get this started. Nkechi, over to you.
Thank you very much.
Thank you very much, David.
I'm glad to have all of you join us from different areas. So welcome to our very first webinar. Virtual. And we do have the unique hashtag for this conversation as changing the conversation. We are very excited to have you all here, and we welcome you all from whatever part of the world you're joining us from. So if you could take a moment, please just go to the chat box and let us know what part of the world you're joining us from today. And maybe also share with us one key lesson that you want to take away from the discussion today. So welcome once again. But before we dive into our business for today, I'll take a little moment just to tell you a little bit about SPARC. What is SPARC? SPARC is Strategic Purchasing Africa Resource Center. And we are a resource hub in sub-Saharan Africa, supporting countries with knowledge and practical tools to make access to good quality and equitable healthcare a reality for all. SPARC typically supports countries to make the best use of limited resources in their journeys towards universal health coverage. And you will all agree with me that given COVID and how our already limited fiscal spaces have been constrained, this conversation about making the best use of limited resources cannot be overemphasized. There are two key approaches that stand out for us in our work. The first is that we take a functional approach to strategic health purchasing. What does that mean? It means that we never think about strategic health purchasing as a scheme, as a program, as an intervention. We always look at strategic health purchasing as critical decisions that a purchaser has to make about what to buy, speaking about benefit specification, about who to buy from, talking about provider contracting, and about how to pay, talking about whether you're going to pay the provider prospectively or retrospectively, talking about the rate that you're going to pay them, and then of course, monitoring their performance. So this is our functional approach to strategic purchasing. The next key approach to the work that we do is the fact that at SPARC, the countries are in the driver's seat. And so that means having the countries lead the conversation on who supports them, how this support is provided, and what reforms that they're supported to work on. And so for us at SPARC, in our practical everyday lives, this means that we continue to leverage and to mobilize regional and country experts who have technical and complementary soft skills to support country processes. Now, this concept of having the country in the driver's seat is really one that our policy dialogue series recognizes. Understanding that countries in sub-Saharan Africa are the ultimate consumers of this information that we will share throughout this series. Information that we jointly generated with them and that we are disseminating in collaboration with them, using a mix of high-level panels and facilitated discussions with policymakers. The 4-part policy dialogue series, which will be held between May and July of 2021, seeks to increase awareness of strategic health purchasing in Africa and shift its current focus from interventions and schemes to a system-wide functional approach, as I already described. Specifically, during today's session, we will share and reflect upon the findings from the strategic purchasing functional mapping that was carried out by our technical partners. And then we're going to use the outputs from this work to spark a discussion among African policymakers about how these results can be translated into action for continued progress on strategic purchasing for health system improvement. It's also our hope that by the end of this series, providers of technical assistance to countries will have an opportunity to reflect on the key messages from these webinars and what their implications are for future support to countries. So I invite you all to engage. As Dari has said, tweet out your comments or any deep insights you're getting from this conversation using the hashtag #ChangingTheConversation. Ask questions, and please also share your own implementation experience and challenges in the chat box. We will take as many questions as possible, and where that's not possible, we're going to collate all of them and share responses to you with you on our website. And with that said, I welcome you all to this webinar and wish us all fruitful deliberations and engagements. You are welcome. You are welcome. Back to you, Dan.
Thank you so much, Nkechi, and that was very, very succinct and clear. Nkechi had mentioned that we're looking at strategic purchasing from a functional approach. I would now invite Cheryl Cashin. Cheryl is Managing Director for Results for Development, to really walk us through what we really mean by this functional approach to assessing and describing strategic purchasing within a health system. Cheryl, over to you.
Thank you so much, Dari. Good afternoon, everyone. Good morning to some of you. So my name is Cheryl Cashin. As Dari said, we at R4D are a technical partner to SPARC and help to work through some of the technical issues around strategic health purchasing. But as we'll discuss today, this is not only a technical journey, But we'll start with some of our foundations, what drives the thinking and the functional approach that we'll be sharing today to get at these very specific lessons that we'll hear from our panelists from the countries that we've been engaging with. So you've been hearing this term now, changing the conversation. What do we mean by that? Changing the conversation about strategic health purchasing from what to what? So I think we want to be very clear that we are changing the questions that we're asking. That we typically ask questions like, does this work? Does PBF work? Does capitation work? And we're finding that particular question is not that helpful. So we'd like to change the conversation to starting with a different question. What drives progress? What drives progress for countries to get results in their health systems using the very powerful toolbox of strategic health purchasing? So what do we mean by that? And maybe the next slide, please. And this is the theory of change that we have co-created with SPARC and our technical partners, what we think can actually drive progress to strategic purchasing. And what we'll be spending the next 90 minutes doing is testing this theory of change. But this theory of change starts with the engine of strategic health purchasing, and that's that circle in the middle, the functions that Nkechi mentioned, the functions of specifying what you're going to buy in your system with limited funds, which benefits are you going to allow the population to be entitled to, which providers are you going to contract with to deliver those services in the benefit package, how will you pay them, and how will you monitor their performance to know that you're getting what you're paying for. So that engine of strategic health purchasing, these functions are what need to be strong with good policies, good operating systems to get the results in the system that we hope for. But we know this is not just a technical exercise. For these functions to perform well, they need to be supported by good institutional arrangements and capacities, good governance structures and accountability mechanisms. And even before we get to that, we need to have awareness and political will and evidence to actually know what is out there, what is available, what has worked in other contexts, and how you might adapt that for your own context to make progress. So this is our theory of change, but we also know that all of this alone will not bring results, that you need a good enabling environment. Can health providers actually respond to the incentives in the system that you create with your purchasing arrangements? Are the public financial management systems also supportive of this kind of allocation of funding and use of public funds? We also know that there are some external factors that are outside of purchasing and maybe even outside of health that can influence whether or not these purchasing functions have power to create the incentives that we're trying to create, to change the behavior of providers, have power to shift how resources are allocated. And those external factors become very important. And we'll talk about that as we go along. Next slide, please. So that's our theory of change. How do we translate that into practical knowledge, practical information that countries can use to drive progress in their own contexts? So SPARC is a resource hub, as Dari and Nkechi mentioned, and this resource hub connects to partners all across Africa, all across Anglophone, Francophone, all of the parts of Africa, to bring in different experiences with different contexts and really learn together how to move along that theory of change and actually make progress. Next slide, please. So these technical partners have been working together for the past 2 years to unpack this, to go deep into this theory of change, to deeply understand what it takes to build good purchasing functions, what it takes to allocate those functions to institutions who have the capacity to carry them out, have the mandate to carry them out, and actually navigate the external factors to get results. So the technical partners went deep into the theory of change and have co-created this framework. This is our functional framework for tracking progress on strategic health purchasing. And this framework builds on other frameworks that others have developed previously. It builds on the RESIST framework, the RESIST Research Consortium. It builds on the World Health Organization's health financing progress matrices, and a lot of other thinking and literature that's out there. Try to bring it all together in one framework that covers all of the key elements of a health purchasing system. and to dig in and find out what was happening in all the countries and what we could learn from that about what it takes to drive progress. A very important part of this framework is that it isn't looking at one scheme or one part of the system. This framework is applied across all health financing arrangements in a country, because it's not only important to get things right within a scheme, but how do all the health financing arrangements in a country work together, or sometimes against each other, to get the health system results that we're trying to get in the countries. Next slide, please. So all of the partners working together with SPARC, 11 partners in 10 countries, worked together to build this framework, and were able to apply it in 9 countries, and work together with their policymakers, looking at published, unpublished literature, any source of information that was available to really understand and put together the pieces of the health purchasing functions in their system. We were very fortunate to be able to come together in Cotonou, in Benin, in January of 2020, before the global pandemic of COVID-19 hit, and to share and discuss some initial findings of the application of this framework, what was happening in these countries in strategic purchasing, what lessons could be learned about how to build strong functions and governance structures, what are some of the external factors that were either helping or impeding progress. And we had some excellent discussions at that time, and were able to generate some early lessons. And what we found is just the use of a framework like this, looking at functions instead of specific schemes or instruments, made the conversation very practical. It was a very practical foundation for the conversation between technical experts and policymakers. We were able to look at very specifically and in detail where there was good progress to build on, and where maybe there were some obstacles and where some investments or new policies or new approaches would be needed. And I have to say, all of this accomplished something else. It depoliticized a conversation which can often be very fraught, because at the end of the day, strategic health purchasing is about changing how funds flow, changing how money gets to providers, changing how money is accounted for. And so to look at this very functionally helps to make that conversation depoliticized and more practical. So I'm going to give you a preview of some of the lessons that came out of those early discussions, and we're going to dig into these in a lot more detail over the next 90 minutes. What we found when we looked at the strategic health purchasing functional mapping across 9 countries is that there was a lot of progress. There were a lot of pockets of progress in improving strategic purchasing functions. Where we saw the most progress is all of the countries have been able to define benefits packages or service packages that prioritized the services that should be made available to which populations in order to meet health needs. We also saw a lot of progress on contracting. Even in systems that still rely mainly on the budgets to pay providers, they were able to build in new contracting mechanisms. And that really, the combination of these two things, being clear about what you're buying and how you're going to enter into contracting arrangements with providers to deliver those services, really formed the cornerstone of additional, more sophisticated strategic purchasing approaches. So they formed the cornerstone, and most of the countries have made progress on those areas. And they also found that it was critical that the providers of services that were contracted had the flexibility to use funds at the front line to manage the health of their population and to direct those funds where they could bring the most need. And all of the countries were doing something to analyze data, to understand how the purchasing systems are working, and to see how the performance of providers was affected by changes in purchasing. So although there was all of this progress in individual functions, the technical partners were not able to show large-scale results. So why is all this progress happening in strategic purchasing? And we're still not seeing the big results on the other side in terms of resource allocation being better and getting better access to services, quality and equity, all of those outcomes that we're trying to get, we were not able to connect on a large scale to these strategic purchasing pockets of progress. And what we found, there were some stumbling blocks along the way. And the main one which will come as no surprise to anyone here, I think, in the webinar, is that there is so much fragmentation in the different health financing arrangements, and the actual amount of money flowing through these strategic purchasing mechanisms is often very small, too small to exert any power on the behavior of providers. So that's the big external factor that really the countries are grappling with and really limits the power of strategic purchasing to bring results. We also saw some challenges within the policies themselves in the purchasing functions. One of the big challenges that the countries are facing is that they were able to move away from line item budgets to more output-oriented payment system, payments linked to the services provided. But those payment systems are typically open-ended fee-for-service, and it's not a very strategic way to match payments to the services that are delivered with quality and other objectives. So that open-ended fee-for-service payment, although a step towards more strategic purchasing because it's linked to services, actually was bringing some financial sustainability challenges to a lot of the countries. And then finally, there are issues that are quite operational. You might have a good system that has been defragmented with good policies, good provider payment systems, and your functions are working well. But if you don't have good operational systems that generate good information, that have low administrative burden, that make sure that providers are paid on time, that can also undermine your system. So these are three messages that I would like all of you to please take with you as we go through the session today and we hear from our panelists these lessons, how important it is to look at the fragmentation in the system and try to work towards defragmenting, consolidating the health financing arrangements. At the very least, don't add new fragmentation to the system. The second lesson is that when you're looking at your purchasing functions and the policies within them, that they are a very powerful opportunity to link these purchasing functions and policies with your objectives. So being very deliberate to have objectives-oriented policies within your health purchasing functions. And then the third lesson is about making sure that the operational systems you have in place generate good information and don't add administrative burden that can undermine the power of strategic purchasing. So these are some messages that we learned from this exercise across the 9 countries, and I think there'll be themes that carry through our discussion today. And just finally, on the last slide, please. Where do we go from here? Looking at all of the lessons that came out of this exercise, the technical partners and SPARC were able to look across and come out with some benchmarks. How do you know if you're making progress? Are you going in the right direction in your strategic purchasing system? And so looking at some of the existing frameworks and normative guidance out there from RESIST and WHO and others, other published literature, the SPARC consortium came together with a set of benchmarks or guideposts so that you know if you are going in the right direction and moving your functions in the right direction, your governance structures, and then you can look how all of that fits in with some of the other external factors that you might also need to manage to continue to make progress for large-scale sustainable results. Thank you, Dari, back to you.
Thank you so much, Cheryl. Thanks for setting that tone into the conversation. Now we're going to go into a panel discussion. We have our panelists ready from the different countries that we have engaged with in the last couple of years. And I will be introducing the moderator for this session. Our moderator is Nat Otto. He is an independent consultant and also a senior fellow at Results for Development. Nat, you're welcome to take it from here.
Thanks so much, Darren. And we couldn't have had a better start to this session than the framing that has been done by Cheryl, and also the introductory comments by Nkechi and your good self. I am excited to be on this webinar, moderating a conversation between an amazing array of experts that are going to shed light on what is happening in their various countries. In my prior discussion with them, I told them they have a story to tell, and I'll leave them to tell that story, but I'll only just leave them in the process of doing so. Having said that, the groundwork that Cheryl laid is extremely important, because when the mapping exercise was done, it was found that a number of themes run across countries or run through countries. And some of these are what she laid out: fragmentation, how do you put together political will to advance to strategic purchasing, but also how to deal with the public financial management issues that lead often to delays. And I would assure you that our panel here has experience in dealing with all these challenges, and it will be a great thing to hear from them today. First, we have Raymond Kiwesa. Raymond is a principal health administrator who works with the President's Regional Office Administration and is a local government coordinator for direct health financing project in Tanzania. He has a rich background in health, having a bachelor's degree in health administration and master's degree in health systems management. He has been an integral part in putting this whole new wonderful approach in Tanzania together. And so we expect to hear what he has to say about the progress that has been made. Next, we have Dr. Regis Sitimana. I actually refer to him as DDG. It's the acronym Deputy Director General. He's the Deputy Director General of Rwanda's RSSB, which is Rwanda's Social Security Fund. He's a health economist with a rich experience in national health policy, having worked at the Ministry of Health and also having a background working with NGOs. He was appointed as Deputy Director General in 2020, having lectured immediately before that at the University of Rwanda's College of Medicine and Health Sciences. Next, we have Dr. Lydia Janiselby. Dr. Lydia Janiselby is a doctor by profession, specialty in ENT. She attended medical school at the University of Ghana Medical School. She is currently the CEO of Ghana's health insurance scheme. And I would say that she has gone through the mill of health insurance, having held various positions, and she has actually the entire story of the NHIS, having been with it almost from its infancy. And so I want to welcome all of you, but I can't stop without saying that Dr. Selby also plays quite an important role internationally, having been co-convener of the Joint Learning Network, a network of 34 countries that are striving to achieve UHC through peer learning. So panelists, you're all welcome. It's great to be with you, and I really look forward to this session. Now, I want to just remind all participants of this webinar that we really appreciate your inputs and also your contributions. I do know that there are people who would have wished to share their country experiences, but it's not possible to put all of you on the panel. So if there is anything special that you can share with us by way of lessons, we'll be excited to hear from you and to share that with our fellow participants within this webinar, but also after that to curate these bodies of knowledge to share with the rest of the continent. And also to invite you to post your questions. As you know, sometimes it's very difficult to get people to speak on a webinar of this nature because of the technology involved, but also because of the time constraints. So we invite questions. We have a team that is looking at those questions, and they'll pick and choose some of the questions and put them up for consideration. But at the end of the day, all these questions that are not answered will again be curated and shared. So thank you very much. Welcome to all of you. Now, I start shooting straight, by asking my first question to Dr. Selby. I call her Lydia. So Lydia, tell me, I mean, in Ghana, you have been at this whole thing of, strategic purchasing for quite a long time, having set up a health insurance scheme as far back as 2003, and going through the various stages and getting to where you are right now. I do know that we came from Ghana from a point of a lot of fragmentation, not only in the functions of purchasing, but generally in all those functions that attended the health insurance as it is in Ghana. And much as we know that health insurance is not synonymous with strategic purchasing, nevertheless, a lot of things that you're doing is leading us to embrace strategic purchasing in Ghana's health insurance. How have you consolidated the purchasing functions in Ghana? How has this been possible politically and technically? And can you share some examples of consolidation with us? Over to you, Lydia.
Thank you very much, and thank you to all our participants. Next slide. So just a bit of background, Ghana has a population of about 30.4 million with a GDP per capita of 2,202. And this puts us squarely in the lower middle income bracket. Next slide. And to give a brief overview of the characteristics of the NHIS, we had legislation in 2003 and it was amended in 852. Well, it was repealed and a whole new law was brought in. The purchaser is the National Health Insurance Authority. Currently, we cover 52% of the population. It is on the rise, and it's mainly on the rise in the informal sector, which is very encouraging. The enrollment is mandatory, but as we all know, enforcement in our environment is quite difficult. We have a benefit package that covers about 95% of the health conditions, and the contracts are with public, private, and faith-based providers. The sources of funding are mainly earmarked, which is a 2.5% consumption tax and 2.5% of social security contributions of the formal sector. And the payment methods, currently outpatient and inpatient, are by diagnosis-related groupings. We had the G in front to show that it was done by Ghana itself, and the medicines are free for service. We flirted briefly with capitation, and we're going to have to relook at it. Next slide. So consolidation of the purchasing. I think the important point was to have a law that actually separated purchasing and service delivery. That was key. And putting in all the governance structures. I think Cheryl has brought it up. We have very good political will. The two major political parties are both united in the cause of the National Health Insurance Scheme and therefore strategic purchasing. We've reduced fragmentation. We had about 150 mutual district schemes, which is now one unitary scheme with one bank account, pooled funds, and proper financial controls and accountability. We have earmarked funds which constitute about 90% of our inflows. And much as sometimes a consumption tax can be regressive, ours has been shown through research to be quite progressive. And we have targeted exemption policies to make sure that the vulnerable in our society still have good access. Looking on the technical side, we do provider contracting. It took us a while to get there, but we got there. And this really sets out the process by which the health services will be delivered. We have credentialing standards, so everybody must have credentials which looks at the services delivered as well as the staffing. Electronic claims processing is in its infancy. About 30% of our claims now come electronically. We have a quality assurance directorate that does medical audits. This allows us to have some view over the quality of care being given and some monitoring and accountability of what is delivered. We now use USSD mobile technology for members to renew and also authenticate every visit at the facility site. This allows us to actually know in advance roughly how many people utilize services. So we have a rough idea of the claims that will be coming in and are therefore prepared. We have an NHIS medicines list. You cannot prescribe outside the medicines list. It has about close to 600 different formulations. And each medicine has its level of prescriber who is actually allowed to prescribe. This allows us to contain costs and make sure there's safety for the patients. And we've just started framework contracting for about 60 of the medicines on our medicines list. This, we hope, will help us to control costs because medicines are still paid through fee for service. Next. Now this slide, I decided to pull out the data on the electronic claims over the last 3 years, January 2017 to the end of December 2019. Now, if you look, service costs and medicines costs that we pay in claims has stayed virtually the same, yet we've raised the service costs and the medicines costs twice within this period, each time by almost 20%. Yet it sort of rises a bit, and then all our measures bring the prices back down. This, we hope, shows an indication that the strategic purchasing we're doing is helping us control costs. Next slide. Now, this is actually cost per visit and percentage of medicines cost within the claims cost. Now, when you're doing strategic purchasing and you hope it is working, you expect to see all your providers of the same type clustered together. And this is what we see here. We have the majority clustered together of the same type of facility, providing the same type of services. And obviously, we will use this to pick out the outliers, and that will allow us to investigate them a bit more. It doesn't mean they are doing fraud or anything like that. It just means that there may be some policy we need to look at to bring them in line with the other providers of their caliber. Next slide. So lastly, what are some of the things that are hurting us in our bid to be a strategic purchaser? At the moment, we're a bit passive in our strategic purchasing, and we need to be a bit more active. One of the issues is the ability of the service providers to respond to the levers we're trying to pull with the strategic health purchasing. Our biggest service provider is the Ghana Health Service, and that is very centralized. And sometimes it's difficult for the providers to actually respond to the lever we're trying to pull. And therefore, when they find themselves in difficulty, they respond to illegal co-payments or something else. So there's the need to look at how the providers can really respond appropriately to the policies we put in place. We have limited real-time data analytics ability, and sometimes it takes almost a year before we notice some of the issues that should be addressed with policies. Data, but there's very poor network coverage in rural areas. So the data comes in manually and has to be converted before you can make meaning of it. And then, as we all know, countering parochial interests and interference, it requires a lot of communication and advocacy to counter this. So the way forward for us is full digitization drive. We need to have, it's easier to make decisions, to have data, to monitor and hold people accountable. We need to build the strategic health purchasing capacity in the country. It's no good the health insurance having that capacity if our providers don't have the same understanding and capacity. And the last thing we are really trying to drive now is communication, to really understand, for everybody to understand the direction we all want to go in to achieve UHC. Thank you very much.
Thank you so much, Lydia. It's so packed. I mean, I can see there are so many things happening. It's really amazing for you to be able to share this in this short period. But two things scream at me, and it's really you're alluding to the fact that there is need to involve, the providers a lot more, and also be good at communication. Thank you very much. We'll come back to you on some of those issues you have raised. Now I go to DDG, as we call him affectionately. DDG, I went to Rwanda the first time, I guess about 14 years ago. And I mean, at that time, the CBHI was in its nascent stages. And I've returned back and back again to the country, I think about 5 or 6 times. And the last time I went to Rwanda, it was amazing the progress you had made. And what is even more amazing is how you're looking forward, in the next 10 years to make strategic purchasing a hallmark of your health finances system. Now, talking about Rwanda and looking at where you've come from, you started with so many CBHIs, they're still there, but now they're all under the RSSB. Tell me how you were able to politically and technically consolidate all these functions, and also examples of how these consolidation has improved the purchasing functions of the RSSB.
Thank you very much, moderator. Maybe before responding to your specific questions, I don't know, probably many people know Rwanda, a small country in East African part of the continent, with close to 30 million population and slightly higher than $800 per capita, which makes us a low-income country. And talking about CBHI, this is a community-based health insurance scheme that was created in 1999, particularly to address two main issues. One was the user fees, and second was the low utilization of healthcare services. And this was only 5 years after the genocide against the Tutsi, which is for us, for the country, which was like starting from afresh. Immediately after the genocide against the Tutsi, in the first few years, the services were free. And when the government wanted to reintroduce the user fees, utilization, which was already low, went even deeper low. And I think the necessity to create CBHI was obvious from then. And this is a scheme that is targeting the people in the informal sector, because you have other schemes that are targeting formal sector, the civil servant, the men in uniform, and other private health insurances. And it is financed through annual premiums collected from households based on their socioeconomic capacities. Of course, they didn't start like that. There's a long history, which I can't cover in the 5 minutes that you gave me. But at least now, every household, we have a registry that determines where every household is recorded, and we can know which category, socioeconomic category they belong to. And the premium is set for that household according to that category. And of course, in addition to that, there is substantial government subsidies that are complementing those premiums, starting from covering the poorest. Close to 16% of the households are 100% supported by the government. And it's there because we do all this mobilization every year, and we try our best to keep the high enrollment with very good, very high political commitment to make it possible. Because I know similar schemes were created in the last few years, but standing for more than 20 years is something different. So talking about consolidation of multiple pools, when it was created in 1999, it was multiple schemes. Every district had its own. So they were organized in a way that they could collect premiums, provide primary and secondary healthcare services, while the government is topping up with the tertiary services. As they kept growing, there was a realization that we needed a national coordination structure. And at that time, there was a small unit in the Ministry of Health, which was bringing all the schemes together, trying to support cross-subsidization, support the district in management of the schemes. But as the small schemes kept growing, it was imperative that we needed to have a strong central coordination body. And when you look at the right, the chart at the right part of this presentation, this is a typical chart of an annual report of the schemes. Some of them making a surplus, while others are in negative. So some were not sustainable at all, just because they are unable to mobilize enough premiums, or because the burden is so high. For example, we have close to 4 districts that are covering more than 70% of the burden of the road traffic accidents. Imagine how much they have to pay to the hospitals, while the premiums are almost the same as other districts. So some had a lot of burden, high burden and low premiums. Others were fairly better in financially. So government had to go in and collect some surplus from some schemes and go and support others. But it was a process that was making it, that was becoming so complex over the time. And in addition to that, during the creation, patients were supposed to be covered by their own scheme. When you get sick, when you are in another district, that was something that was not provided for. When it was created, then it created another cumbersome process of reconciliation between schemes. So all of this has led to the decision by the government to make one scheme, managed centrally, and because the Minister of Health was also responsible for health facilities, setting policies, so it was found itself having a triple role in this, setting policies, provider, and purchaser. While on the other side, there was another institution that had more than 10 years experience in managing other civil servant scheme. And the decision was taken to leave the ministry with the 2 other functions, but let the purchaser be aside, as those roles have to be separated. And of course, that had to be followed by other measures to make that mobilization continue. And there is a strong government coordination between institutions, the Ministry of Local Government and their district administration taking over the mobilization part of it, the ministry coordinating the service provision, while as RSSB, we only focus on the purchasing function. And we kept seeing the trust between population and the government increasing, because every time we were able to settle the bills, to pay the facilities, and patients were able to see the services the way they were expecting. Next, please. And what was the implication of this on the purchasing function? So actually, as I said, those multiple pools didn't have adequate provision for risk distribution. Some were in a very poor financial positions, others were better off, but still, in the long run, we know the economics of insurance. Without a scale, there is no small scheme that can be easily sustainable. So now we are collecting all the premiums into one national basket, and that basket is responsible for providing care from primary health care level to secondary to tertiary level. And by bringing it to the institution that had a lot of experience, actually in the same day of transfer, we were able to make some efficiencies, especially on the financial management part of it, where more than 500 positions were found redundant because of having already a financial system working. We didn't have an accountant in every small scheme, a small unit at the central level, and a strong IT system could handle this. And we have been able, and the way, when you look at the whole, how the schemes were working, some that were better off could use the surplus in a way that when you look at it is not efficient, because we have more money. Our neighbors have a gap. We have more money. We can plan for supervisions, for things that usually we are not doing, but still making a good progress. So because it is a national pool, then we see where there is a problem and we address it holistically. And we have seen an increase in enrollment, actually, because it was when the institution started managing this scheme, there was a realization that we needed to have a central registration system, which was immediately automated. And we could see that all these mismanagement behind manual processing of contributions and registration of new members, we have been able to see that enrollment growing. And what we have seen also in the last year is that the scheme, given all these 6 years since putting the scheme into one pool, we have seen it resilient to COVID. Both new collections and service provision, the scheme was not much affected. Of course, thanks to the government for covering COVID aside, but when we remain with the remaining of the burden, I think we were able to manage, we were able to have in resources as we planned and be able to settle the bills for the hospital. So I don't think that those small schemes would have managed to have this, to be resilient as the national scheme. Next, to be my last slide. We still have challenges, and the more we grow, the more we see challenges. We still have issues that we share with our colleagues in Ghana. We still have manual processes that don't give us enough information we have to be a strong purchaser. And with this, we are working on an automation project, which we think we plan to launch next year. But also over the time, we have seen a cost escalation, which we always attribute it more to the fee for service, which is open-ended, as Sherry was mentioning. And we are discussing with the government to move away from the fee for service to other provider payment mechanisms. And we want also to control the benefit package because we have the service package, but not necessarily a specific benefit package which is affordable and aligned to CBHI resources. And we have seen the government a continued commitment to support this scheme as we have those financial gaps over the years. Recently, the government has enacted new source of funding from taxes on different fuel, telecommunication, and whatever. And we keep engaging with the government to keep CBHI sustainable. Thank you very much.
Thank you so much, DDG. This is really a lot packed into this short, time as well, and it's really eye-opening. Thank you very much. We'll come back to you on some of the issues that you raised. At this moment, I will go to Raymond. And Raymond, one thing I know and I appreciate about Tanzania is your ability to create effective, low-cost, solutions. And so when it came to the issue of public financial management for a tax finance system, you set some very good examples that are worth, sharing. And I want you to share with us how you developed the direct health financing facility and how this has helped you to solve the public financial management issues in Tanzania's health system. Are you with us, Raymond? I think I'll come back to Raymond. I'm not hearing from him, but I just want to dig a little bit.
Hello?
Yeah, Raymond, you're here. Great. So did you hear my question?
Could you just repeat?
Yes, I was just
question,
saying
please.
how your country is really amazing at having, effective solutions that doesn't cost, they don't cost a lot and easy to implement with kind of the resources you have. And I'm just talking specifically here about the lessons the rest of the continent has to learn about the direct health financing facility, which you've put in place to make sure resources reach the front line and to be able to get accountability for those resources.
Thank you very much, Otto. Let me just start by saying that our country, Tanzania, is a vast country with a lot of people, about 61 million people by May this year. And we have a lot of challenges when it comes to health services for our people. But our country, just a short history, has undergone a number of reforms that aimed at improving health services for the people. And within that, we had reforms that involved financial reforms. And this led us to make the country decide in 2016 that we are going for DHFF. In short, this is a modality that was decided by the country, aiming at decentralizing health service management and increasing efficiency through more integration and capitalizing collaboration, and at the end, improving the quality of services that are being provided. The main objective of this reform is mainly to improve efficiency and effectiveness of resources use and management, and to enhance transparency and autonomy, to ensure financial resources go down to the levels of service provision, to allow the facilities to direct them where they will have more impact, but also to enhance community empowerment and ownership of health services and mobilization of resources and planning as a whole. And at the end of the day, improve healthcare delivery, as I have said. This modality is implemented through approved health facility plans and budgets, where the health facilities plan on their own. As I've said, the aim of the DHFF is to increase autonomy of the health facilities where services are being provided. So the facilities have been given the chance to set their priorities and plan and budget for services. And DHFF is financed by a number of sources of fund, including the central government, some insurance schemes like Community Health Fund, the National Health Insurance Fund, but we have funds from our development partners. We have a Health Basket Fund. We have development other funds for that are being injected in the health sector for improving services. So we had these challenges for a long time, and when the government analyzed it, decided that it is high time to go for DHFF that makes the facilities to have efficiency in the utilization of funds that they receive. So we have the modality disbursing funds from the central government directly to the health facility bank accounts. We have block grants from the central government. We have health basket fund. We have funds from NGOs and vertical programs. We have result-based funds. We have funds from insurance schemes, as I've said, and all those go straight to the health facility bank accounts. But again, with DHFF, we have funds that are available at the council level. The cost sharing funds that are being collected by the health facilities themselves, and they are being utilized at the facility level. About the progress of implementation of DHFF, we are in the 4th year of implementation of DHFF in our country, and currently it is being implemented in 184 local government authorities and involves around 5,807 health facilities. And all health facilities are required to have bank accounts where the funds are being disbursed, and the funds are disbursed on quarterly basis so that they can finance their planned interventions and activities. The funds are directed mainly to the interventions where we can see results, like purchase of health commodities and pay other important operational costs in the facilities. With DHFF, what we can say we have tried to solve as a country mainly is, first of all, the amount of resources, financial resources, that was reaching the health facilities, where is the service point. If we compare before and after introduction of DHFF, we can now clearly see more financial resources to the health facilities than how it used to be before. But we have enhanced the transparency and accountability, as well as autonomy. But we are doing evidence-based planning and budgeting at that level, where the facilities themselves prioritize their interventions and plan on their own. We have improved services as well, including the availability of health commodities in that level as compared to what it used to be before. The biggest challenge we were facing before the introduction of DHFF was conflicting, I can say, priorities between the facilities and the local government authorities, especially at the headquarters, where the funds were disbursed and managed. But now we can see clearly that the challenge is fading away, and there's a lot of improvement at that level. We have challenges, despite the fact that DHFF aims at improving services, but we still have challenges that we need that we face, that we see hinder the smooth implementation of DHFF. One is inadequate public financial management at the facility. As we know, as we go down, the level of understanding of the health facility staff is different from, as compared to the higher levels, where we find a good number of financial management experts. So this brings some challenges in managing the finances properly. But again, as far as governance is concerned, the DHFF's management structure has health facility governing committee at the level of facility that is supposed to supervise and provide support to the health facilities in public financial management. But the capacity is still inadequate to enable the facilities manage their finances properly. So this is another challenge that we face. We also face a challenge that some of the funds, including both the donor funds and government funds, that do not follow the DHF modality. But we are trying our level best to advocate for DHF as preferred modality to improve management of health services in the primary level as far as financial management is concerned.
Wonderful, Raymond. I think this is really a wonderful presentation. Again, this is so much to share in this short period. And I think we will be able to follow up with you on these experiences. But having said that, I'll come back to you, with another round. And maybe in this round, I just want to, I'll start with you, Raymond. I mean, so now that SPARC has worked with all these technical partners to develop, the functional mapping exercise and its results, which has been shared with you, would you name one finding from that report or from the mapping exercise that resonates with you in terms of, how it will enrich your progress as a country in Tanzania?
It is very unfortunately that I couldn't get access to the report. So.
Sure. Okay. I'll come back to you. But I will pose the same question to Lydia in Ghana. So I believe you've gone through the report. Is there one thing that resonates with you, that would help improve your journey towards a more strategic approach to purchasing health in Ghana?
Thank you very much. I think it's about all of us being able to be a bit responsive to strategic purchasing policies. It's all well and good having a policy, but if our country context or the environment you're in doesn't allow you that kind of flexibility to respond adequately, then the policy hangs. And I think we have those challenges in Ghana. We have some really good policies that would possibly change the way health is purchased. We all know what to do, but the systems, or I don't think it's the will so much as the systems, the bureaucracy is defeating us at the moment. And we have to bite the bullet and work around it and do some real structural reforms in the health sector if we want to achieve UHC. Thank you.
It's not only the policies, but the savviness of bringing these policies to reality. Thank you very much, Lydia. DDG, again, I will ask you about Rwanda. I mean, one thing that you guys are really good at is how to plan way ahead. Looking at the recommendations of this report or the findings and your 10-year forward-looking plan on health financing, what would you say resonates with you from the report?
Yes, thank you. Two things, and one was already hinted on by Sherry. It's about so bringing all the small schemes together didn't solve the whole fragmentation problems. We still have fragmentation that we need to address. And one of them, when you look at this mapping report, that strategic way of looking at the purchasing functions, not in the framework of schemes, but rather at the strategic purchasing functions, that was like an eye opener for us, because we as RSSB, we are managing the CBHI, the community-based health insurance, but the ministry remained with performance-based financing, and the two don't communicate to each other. We are purchasing same services from the same health facilities, but with two different ways of doing, which are not communicating. And if I give a very pertinent example, recently when I was discussing with one senior person in the ministry, He was telling me, you know, I want the hospitals to improve their quality, and I want to enroll them into the accreditation process. But I don't see interest, because in any case, when there is no financial interest, because PBF is so small, as long as they will get all the payments from the community-based health insurance, they are not interested in following me this way. So he was telling me, can you help me to enforce this? And I was saying, oh, that's the solution actually. How can we bring together your money you still have on PBF, what I'm paying to the facilities, to find a way that we reimburse the services, but also at the same time address the issue of quality of services, because we are all interested in improving the quality of services. I think this report was showing it very nicely, how this can be possible and address the problem holistically. And talking about 10 years ahead, actually, this is the time we are discussing about CBHI sustainability. We have looked at 10 years back, the progress, the trends in revenues and expenditures. And it's also a way of looking at it holistically. Sustainability will not rise from CBHI alone. We need to look at a benefit package. We need to look at provider payment mechanism. We need to look at many things at the level of functions, for which this report has showed the weaknesses, and we are basing on this to plan for 10 years ahead, trying to bring together to improve on each of the functions in responding to the sustainability issue. Wonderful. Otherwise, CBHI itself cannot be sustainable if you keep the same trend of benefit expenditure. We need to look at it at all the functions in purchasing. Wonderful. And with this, we have created one strategic purchasing technical working group. We widened the discussion from the scheme-based discussion to sector wider strategic purchasing discussion. And we think this will continue even after this 10-year plan. The implementation will be followed by that same technical working group. Thank you.
Thanks so much, Vijay. Now, Raymond, in 1 minute, would you describe how you went through the process of getting political will for implementing, your policy of getting monies through the DHFF to the front line? Maybe in just 30 seconds.
Yes. Actually, the DHFF introduction emanated from a joint annual health sector review, and this was a policy meeting that involved the government and development partners. Mm-hmm. And this is the meeting that put forward recommendations to get political will for the introduction of DHFF and its implementation. And this modality, I can say, received a lot of support from the government and from the political community.
Wonderful. So Lydia, I'm going to go to you last. And again, I want you to make a 30-second pitch to the Minister of Health for Ghana about the importance of strategic purchasing.
I think I would show him the progress we have made in the last 4 or 5 years to keep costs down, but be able to deliver, and show him from other countries what they've achieved, and be able to do some projections going forward to let him know that it would help his job if they were to allow the players and agencies underneath to really promote active strategic purchasing instead of the passive things we're doing now. It would make him sleep easier. So if I put it that way, I'm sure he would allow us to push through some of these policy reforms.
Thank you very much. Very rich discussion. Unfortunately, time won't allow us to pose our questions anymore. But Raymond, Lydia, and also DDG, a big thanks to you. Well, the next, we are going to go to the Q&A session. Questions have been fielded from our participants, and they have been curated, and Nkechi is going to lead the Q&A session. Let me say that I would defer the summing up of this session to the end when the rest of the team comes up and does the summing up. But thank you also very much for your wonderful insights into strategic purchasing in your various countries, but also on the continent. And to tell you that in Africa, strategic purchasing has come to occupy a very important place, to the extent that even the AU has made it part of its health strategy 2016 to 2030. So as countries, we need to shine our lights a bit more on strategic purchasing. Nkechi, over to you.
Thank you very much, Nat, and that was a very enlightening session. There are so many questions here. I doubt that we will be able to take all of them, but we will start off what we have, and then what we can't answer here, as I mentioned when I was giving my introductory remarks, we will curate them, we will answer them, we will put them up on the website, and we will share the link with you. So I'm going to just go around the different panelists and pose some questions. Perhaps two at a time, and probably that might even be all that we can take. So the first question here, interestingly, Rwanda also has a similar question, but it's for you, Lydia. And it says, how was Ghana Health Insurance Agency able to cover a large percentage of informal sector population in their scheme? DDG Regis, for Rwanda, you have a similar question, and it says, what has Rwanda done to increase CBHI enrollment, as enrollment has been a great challenge in many African countries? So that's your first. Then the second question for Rwanda and for Ghana, also literally the same. What are the specific barriers that point out fee-for-service as a challenge for a switch to other PPF? So my understanding of this question is, what are those challenges that countries face with fee-for-service that then makes this country start to talk about, we need to change to a different way of paying providers? I know that Ghana, you had done capitation, then DRGs. I know you're also thinking about moving to capitation again, and it's also the same story for Rwanda. So perhaps just to speak to what those challenges with fee-for-service could be. And then for you, Raymond, I have a question here that says, it really talks about when you look at the different purchasing mechanisms in Africa, what are the impacts on health of citizens? Now, in Tanzania, you have done things slightly differently, not really through a scheme, through budget financing. You have this amazing direct health funding that increases autonomy of the providers. Has this actually translated to improved health indicators? So this is the first round of questions. I will then ask Lydia to start us off.
Thank you very much for the questions. The membership, I think for us, when health insurance was introduced, we were in a bad way. Cash and carry was so detrimental to the health of the people that when an opportunity came to be on a scheme that allowed you to get care without having to put a financial deposit down, it made a big difference. And the rural areas took it up even before the urban areas did, because they really felt the issue of not having cash on hand when something happened. Recently, the informal sector has grown because we've made it easier for them to renew. Ghana has a high mobile money transaction use. So when we made it possible to renew your membership on your mobile phone, including, I think they call them feature phones, non-Android phones, using your mobile money, it really changed for the informal sector. No queuing, no having to leave your job, at your own convenience, night or day, a token fee, and you're active. Once we spread that story around, it changed the way the informal sector reacted to the health insurance. Challenges with the payment method. Because we had cash and carry, it was easy to implement with fee for service. but boy, does it leave room for really misuse, I would say. I wouldn't want to say fraud, but misinterpretation and misuse of the funds. And there's therefore over-servicing, persuading people to have things they don't need, letting them come to the hospital too frequently, etc. But the challenge is when you move to DRG or capitation, the misinformation to the public. When the doctor says they're only giving me, $1 to look after you, the patient then thinks $1 is so small. Then they are eager to add cash, not explaining that it's maybe $1 per capita and only 10 out of 100 people will come. So actually, it works out well for the provider. And we probably didn't explain ourselves well enough to the public because we thought we only needed to deal with providers. And even the providers, I think our communication may have not been so clear. So even with the DRG, we go through that where people don't understand that, okay, if this is the cost for this diagnosis, sometimes it's less, sometimes it's more. It evens out. As soon as it's more, they want the patient to pay. And we're still battling that kind of misinformation and miscommunication. It's obviously better for most people most providers prefer fee for service, but it isn't cost effective. And we still have a way to go with communication to get that right. Thank you.
Perfect. Thank you so much, Lydia. So quickly moving on to you, DDG Regis.
Yes, thanks for the questions. I have maybe three words to try to explain how we have achieved this high enrollment. One is consistency. We didn't start with an 80% coverage. We started with less than 10%. And it was going parallel with the utilization. Utilization was low. As the enrollment kept growing, utilization was also going. More people getting benefits and more people enjoying the benefits than sensitizing all the others. So government consistency, we didn't say this is impossible. We kept mobilizing people, showing the necessity to enroll, mobilizing over the years, and we have seen the fruits. What we have seen, for example, last year, around this time, we were in total lockdown, but we kept seeing our accounts growing the way it used to grow. So people didn't even household didn't even need as RSSB or district to remind them that they have to renew their membership. It's that consistency over years that has created that the culture of saving for health, and also on the other side, providing for what we promise, I think is also a mobilization tool itself. Then government commitment, not only central level, but district. Mobilization is not RSSB. Every mayor, every leader, everywhere, they sign performance contract, and the CPHI enrollment is one of them. So if you meet them to give them seats, you remind them about community-based health insurance, paying their premiums. If you meet them in their cooperative, everywhere, people will talk about that because they have it in their mandate. Also, what my colleague from Ghana has talked about is also convenience. How do we facilitate that premium registration and payment? So we have partnered with one provider of electronic services, payment services, to allow people to pay through their mobiles, through their nearest agencies. And of course, one other key factor that I will not forget to mention is the household registry. So you can check how many people you have in the household, how much you have to pay, and be able to pay, or using your phone. So I think making it easy was also a factor behind that. On the second question, fee for service, I don't think I will add more on capitation. We are facing the same challenges. When you project, if you pick the last 5 years, when you project, it's not sustainable at all. There is no justification to what in less than 5 years, we are closely doubling the benefit expenditure. It's the same, almost the same population, almost the same disease burden. It's only over prescription, over provision that can only be handled by changing from fee-for-service to capitation and DRG for inpatient. So that's what I have. Thank you.
Thank you very much, DDG Regis. Then to you, Raymond.
Yes, what I can say is that we have made a lot of progress in terms of equity. First of all, DHFF covers the whole country and reaches most of the people, especially in the rural areas. We have made a lot of progress. First of all, we have moved from, when it comes to resource allocation, we have moved from input-based allocation of resources to output-based allocation, where we have set indicators of performance. The resources are being allocated using a formula which considers utilization of the facilities and with equity, it measures distance from facility and the number or the catchment population in that particular area. So what I can say is that the DHFF modality has improved the quality of care and services that we provide because it is ensured that more people have access to the services. We have started seeing a lot of improvement in terms of indicators, where now the under 5 mortality, for example, is going down. Maternal mortality as well has gone down, and we have reached more people in terms of provision of services to them. This is what I can say.
Thank you so much, Raymond. Thank you, DDG Regis and Lydia. It's been a great conversation. We could go on forever. Unfortunately, we're fresh out of time. I'd like to crave the indulgence of all participants and the panelists for an additional 5 minutes. We may run about 5 minutes over the hour. But thank you so much for all of this great conversation. We're going to put all of this together and share with you. Moving on very quickly to the next parts of this event, where we're going to talk about some of the things that have come out from this work that our technical partners have done. Although today we have only presented the work and conversations from Rwanda, from Tanzania, and from Ghana, our technical partners actually looked across 9 different African countries. They mapped the strategic purchasing functions in those 9 African countries, and they have put together some policy briefs that came up from that. So, introducing Gary. So introducing our policy brief from our technical partners, and all of this is available on our website, and we're actually putting out the link right now in the chat box. So please feel free, click on the link, visit our website, and you can read all the wonderful information that our technical partners have put in here. Handing over very quickly to Cheryl for the wrap-up of this. Thank you all so much for your attention.
Thank you, Nkechi, and thank you so much to our panelists, our moderators, our participants for this incredibly rich discussion. And I think we sparked some new insights today, and I just wanted to pull out a few of them to share as we close. So I promised you that we would have some lessons about fragmentation, about the technical content of strategic purchasing policies. I think the parade is over now, thank you. and about operational systems to support strategic purchasing progress. So just to highlight a few of the wonderful insights from our panelists. So fragmentation, this is really the major obstacle to gathering purchasing power and being able to leverage purchasing to get results and outcomes. And we heard from our panelists that to defragment the system requires a combination of political will, technical steps, and trust. And I think we heard that maybe that's something that is very difficult to get all three of those. And it doesn't mean that you can't start. So we heard that it is possible to start defragmenting at the level of purchasing functions. It doesn't have to always be a top-down consolidation of schemes. And we heard from Rwanda that they were able to consolidate the function of accreditation across multiple schemes, across PBF and CVHI, and make that function more powerful. So you don't have to wait until you can do the top-down consolidation. We also heard from Tanzania that you can consolidate the funding stream at the level of the provider. So when multiple streams are coming in and you can't necessarily defragment upstream, you can at least defragment the flow of funds to the provider level and try to harmonize those incentives and the use of those funds. I think that also speaks to the role of donors in all of this, and I don't want to ignore that some of the fragmentation that we have seen in these mapping exercises really comes from some solutions that were introduced by donors that actually added fragmentation to the system. And in the case of Tanzania, the donors are now part of the solution and helping to defragment. So when you are able to consolidate purchasing power by defragmenting, but also increasing coverage by getting more people into the scheme, and by that also reducing out-of-pocket payments, you're also consolidating purchasing power. When this is possible, we saw some great examples of what the countries are able to do when purchasing power is stronger. And there's a great example from Ghana being able to move towards framework agreements to contract for medicines. And we all know the cost of medicines is one of the most difficult parts of universal health coverage and strategic health purchasing to solve. We also have seen that you're able to make better use of contracts. We heard both from Rwanda and Ghana that when there's more purchasing power defragmentation, the power of the contract to operationalize your purchasing policies is much stronger, and setting the rules of the game and making it clear who is responsible for what. We also heard that what constitutes the right policy in strategic purchasing functions may change over time as your objectives change. So in Ghana, in the early days, when the objective was to increase utilization after the devastating effects of cash and carry on access to health services, fee-for-service was the right payment system. But then over time, objectives change and financial sustainability becomes more of a challenge. Then the objectives for provider payment policy also change. In terms of improving on operational issues, we heard a lot about the use of mobile technology to reduce administrative burden, to provide access to more people to enroll in these schemes or in the systems, to use mobile technology for service authentication, which can also reduce the administrative burden. So we promised you a theory of change and some practical steps. And I think our panelists gave us a really great overview of some very practical steps that countries can take even while they're waiting for the big transformation in strategic purchasing. So just a few more points that came out around this enabling environment. I think we heard over and over again that it is very important to get funds into the hands of frontline providers, whatever that is in your system, and to make sure that the providers have the ability to respond to these purchasing levers. And that's, I think, something that we have seen progress on in all of the countries, but maybe not quite enough. And then just a final thought on some future directions that I heard from the panelists that we want to be paying more attention to. And I will quote Lydia here: data, data, data. So improving information systems, improving on-time access to information so that you can make better purchasing decisions, but also get real-time intelligence about whether or not your system is going in the right direction. We heard more that we need to do a better job about communication. I think sometimes strategic purchasing seems very threatening, especially to healthcare providers. Strategic purchasing means that they want to cut my payment, they want to cut the funds. And we need to communicate better that strategic purchasing is a shared responsibility to steward limited funds in the system to get better outcomes for people. It's a shared responsibility from all of the players. It's not an adversarial relationship, and we need better communication, I think, to get that message out. And then finally, another big message for the future direction is flexibility. Not just flexibility of providers to respond to incentives, but flexibility of the whole system. And Lydia, permit me again to please quote you, but we all know what to do, but we need to bring the system along to be able to do it. And so I think that's a wonderful note to end on. And with that, I hand it back to our MC, Dari.
Thank you so much, Cheryl. Thanks a lot to our panelists and moderators. Thanks everyone for staying this long. Wow, still over 100 attendees up to this time. We apologize for running 6 minutes off schedule, but we hope it's been a very enlightening and informative session for you. We will be having the next session in this series very soon, and we'll communicate that later. Please stay tuned on our social media pages, get to our website, download the products, and feel free to reach out to us again for any questions or clarifications that you may have. Your feedbacks help us to produce more knowledge products and more informative sessions like this. Until our next series again, please enjoy the products that we have shared and let us know what you think about it. Till that time, my name is Oludare Bodrin again. Thanks to everyone. Thank you.